House, respected Emeritus Chairperson Sir, Gulati Sir, Sachdeva Sir, Saxena Sir, V.K. Kapoor Sir, other faculty, senior faculty members, dear colleagues and students. A very warm welcome to all of you for today's CCR. Today we will be presenting a case, a very interesting case of a young male who presented with recurrent episodes of epistaxis and cyanosis since a very long time. So I would invite Dr. Chitresh.
Good morning, respected professors, seniors, colleagues, and my dear juniors. I am Dr. Chitresh Kumar, PG Resident, Department of Medicine, and today I would like to present the CCR of a young patient with cyanosis and recurrent epistaxis. Our patient, a 24-year-old male college student, resident of Karoli, came to the medicine OPD with the complaints of bluish discoloration of lips and fingertips since the last 12 years, multiple episodes of nosebleeds in the last 3 years, and headache on and off since the past 1 month. The patient was apparently asymptomatic 12 years back. He then developed bluish discoloration of lips and tongue, which has progressively deepened, later involving the digits. Patient came with these complaints 10 years ago to MGH and was evaluated. He was managed conservatively and was advised to be on regular follow-up. Patient continued to do his daily routine activities, including going to the school, playing sports, and doing well in academics for the next few years. Now, since the last 3 to 4 years, he has started having complaints of recurrent episodes of epistaxis, for which he took multiple consultations and was managed conservatively. He used to have 2 to 3 episodes per month, which was small in amount and resolved with medications. Patient now presents with headaches in the last 1 month, which was generalized, non-radiating, mild to moderate in intensity, and dull in character. He used to have headache 1 to 2 times per week, lasting for a few minutes to hours. There was no recent change in vision or behavior, no loss of consciousness or any episodes of seizures. He did not complain of nausea, vomiting or photophobia. Headache was relieved by medications and there were no aggravating factors. With the above history, there was no history of any shortness of breath or palpitations, no history of syncope, skin rashes, weight loss, cough, sputum production, fever, recurrent infection, bleeding from other sides, joint pain, or any drug or substance abuse. There was no history of diabetes mellitus, hypertension or tuberculosis, no history of medications apart from the one he has been taking for his nosebleeds, and there was no history of any trauma. He has no addictions, he is vegetarian by diet and has normal bowel and bladder habits. Family history: his mother died of a neurological illness at an age of 30 years, possibly CVA, with a query of intracranial hemorrhage. Both of his siblings are healthy. So to summarize, we have a timeline. In 2012, he started developing bluish discoloration of lips, tongue and digits. In 2019, he started having complaints of recurrent epistaxis along with progressive bluish discoloration of lips and digits. And now in the year 2023, he has presented to us with the complaints of generalized headaches. So to summarize, we have a 24-year-old male with bluish discoloration of lips, tongue and digits along with multiple episodes of nosebleeds and headache. I would like to ask the house, what are the possible diagnoses? I would like to now enumerate the causes of cyanosis. Cyanosis can be divided into central, peripheral and mixed causes. The central causes include the anatomic shunts, which include the cyanotic heart diseases, pulmonary vascular malformations, cerebral hepatic peripheral AV fistulas. The impaired pulmonary function include causes like pneumonia, pulmonary embolism, acute respiratory distress syndrome, upper airway obstruction and pulmonary hypertension. Other causes including high altitude and polycythemia. The peripheral causes can include low cardiac output, Raynaud's phenomena, arterial obstruction, drugs and polycythemia. With the mixed causes including left ventricular failure. So, with the relevant history, we've ruled out the following causes. And we are left with cyanotic heart diseases, pulmonary vascular malformations, cerebral hepatic peripheral AV fistulas and polycythemia. I would also like to enumerate the common causes of epistaxis. The local causes include nose picking, allergic or viral rhinitis, foreign bodies, chronic excoriation, Hansen's disease, neoplasms such as nasopharyngeal carcinoma, use of intranasal drugs, and facial trauma. Bleeding disorders, which include the use of anticoagulants, thrombocytopenia, hemophilia, von Willebrand disease, and hereditary hemorrhagic telangiectasia, and systemic illnesses such as hypertension and heart failure. With the history, we ruled out the following causes. On admission, the patient's vitals were: he had a pulse of 68 beats per minute, blood pressure 120 by 80 mm of Hg, he was afebrile, saturation on room air was 72%, with a respiratory rate of 14. On initial assessment, patient was moderately well, comfortable, conscious, oriented to time, place and person. On general physical examination, clubbing and cyanosis were present, and rest everything was within the normal limits. Cyanosis was present around the lips, tongue and digits, and he had warm extremities. He had selective bulbous enlargement of bilateral upper and lower limb digits. There was grade 3 clubbing present, and parrot beaking was seen. On head-to-toe examination, multiple mucocutaneous telangiectasias were seen in the oral cavity on the tongue. The patient had a right side mid-back scoliotic deformity with right scapula more prominent, and rest all the examination was unremarkable. On cardiology examination, there were no visible abnormalities in chest and neck, no pulsations or heaves were noted. Apex beat was located in the fifth intercostal space in the mid-clavicular line, which was normal in character. No palpable thrills were heard. On auscultation, normal S1, S2 were heard, with no additional heart sounds or murmurs. On respiratory examination, there was a right scoliotic deformity seen, chest was elliptical in shape, and no scar marks were present. On palpation, the trachea was central, normal respiratory movements were present, and normal chest expansion was seen. Percussion was resonant over the lung fields. On auscultation, bilateral equal vesicular breath sounds were heard, with no adventitious sounds. Other systemic examination was within the normal limits. Investigations and admissions were: he had a hemoglobin of 17.5 gram per deciliter.
Sorry. In a patient who has recent onset headache, young man, you can't just describe that CNS was wrong. Probably you need to spend a bit more time you are presenting in the exam. I think the examiner would like to have it.
Thank you. So, we've seen that we first asked for the
ब्रीफ में बोल दिया अब बोल दो क्या क्या चीज रेलेवेंट
so it was mild to moderate in intensity. Then there was no loss of consciousness, there was no history of seizures, there was no history of any vomiting or
एग्जामिनेशन में पर के कुछ चीजों को स्पेसिफिकली जो हमने देखा
higher
हुआ है
mental
उसको
function.
बोलो
So he had normal higher mental function. The MMSC was 30 by 30, sir. So he had all the cranial nerves were normal, sir. And there was he had normal power in all the four limbs. He was moving all the four limbs.
what was the fundus? Yes.
So there was no papillary was there.
These are things that have to be spoken. So, why I said this, that if the patient has a symptom related to an organ or system, then you are describing the examination, even if it is normal, you have to say that you didn't find this. So, for cervical residence, suppose there is a patient with jaundice, you have to say whether gallbladder is palpable or not.
Investigations on admission. He had a hemoglobin of 17.5 gram per deciliter. Hematocrit was 52.2. MCV was 120.4. MCH was 40.3. WBCs was 6400. Platelet count was 1,20,000. Reticulocyte count, ESR were within the normal limits. The PVR showed macrocytic RBCs with anisocoiculocytosis and few teardrop cells. Liver function tests were within the normal limits. The coagulation profile was within the normal limits. IRTs and electrolytes are within the normal limits. The patient had a normal TSH and was vitamin B12 deficient. So now,
sorry, go back to the hemogram. Whenever you are projecting a slide which has numbers, you don't have to read the numbers. Everybody can read it. You have to interpret, to say that what are the abnormal findings here.
So the patient had polycythemia.
So say that the patient has polycythemia. If you want to emphasize, you can say with a hemoglobin of 17.5. What does IMCV and IMCH indicate?
So it indicates a macrocytic picture of the RBCs. So,
give the interpretation also when you are showing that.
Sure, thank you.
What is the reason of cyanosis and polycythemia? Blood cells are there, red blood cells full of oxygen, but still the patient is cyanotic. What is the reason?
Because for cyanosis, we do not go by the relative hemoglobin, we have to go by the absolute hemoglobin content cell. So if it is less than 4 gram per deciliter cell, then we have to say that the patient is, then we have cyanosis. That happens in.
Very simple mechanics apply. No, it is the flow of the blood. Because of the viscosity, there is sluggishness in the flow of the blood, so the oxygen is not properly reaching. Despite of oxygen is there, it cannot reach to the cells, the organs. And what will happen? It is the viscosity and the slow flow which is responsible for the cyanosis in polycythemia. Am I right?
What happens to the increased viscosity and this product? What happens to the ESR?
Just yes, yeah. See? So this
What happens to the
ESR?
ESR? This polycythemia.
So it will. So polycythemia. So there's polycythemia, then it will decrease. So the ESR will
Will?
decrease. Sir.
Yes. That is because of the increase.
So viscosity. Sir. So now we have a 24-year-old male with cyanosis, clubbing, multiple episodes of epistaxis and polycythemia. I would like to ask the house what would be the possible diagnosis. After ruling out from the cause of cyanosis, we were left with anatomic shunts and polycythemia. To enumerate, we have causes of bilateral clubbing which include the pulmonary causes such as malignancies, including lung cancer, pulmonary metastasis, mesothelioma, thymoma and lymphoma, bronchial causes such as cystic fibrosis and bronchiectasis, interstitial lung diseases, infections such as pulmonary abscess and tuberculosis, vascular causes such as pulmonary vascular malformations, hepatopulmonary syndromes, cardiac causes including cyanotic heart diseases, infectious endocarditis and atrial myxomas, GI causes including inflammatory bowel disease, primary biliary cirrhosis and chronic hepatitis. With the given history, we ruled out the following causes and left with these differentials. On further evaluation, a chest X-ray PAVU was ordered. It was suggestive of a homogeneous opacity which was seen in the left lower zone of lung. On further evaluation, a 2D echo was advised and it was within the normal limits. So now we have a young male with clubbing, cyanosis, polycythemia, and the X-ray suggestive of a homogeneous opacity in the left lower zone of lung and normal 2D echo. What further investigations would you like to advise? A CT angiography of pulmonary vessels was requested and radiology opinion was taken. I would like to invite Dr. Tanya from the Department of Radiodiagnosis to discuss the CT pulmonary angio and the chest X-ray findings.
Good morning, everyone. I'm going to discuss about the radiological findings. Starting with the chest X-ray, there was a homogeneous opacity seen in the left lower lung zone with no obvious calcification, and also scoliosis of the dorsal-lumbar spine was noted with concavity towards the left side. Except the spine, rest of the bones appears normal, and rest of the lung zones also appear to be normal. Bilateral CP angles were also clear. There was no evidence of any free fluid was noted. And in view of the chest X-ray, further CT pulmonary angiography was advised. This is the non-contrast image showing the lobulated soft tissue attenuation in the anterior and the lateral basal segment of the left lower lobe, and rest of the lung parenchyma appeared to be normal, and also the chest was also normal. And this is the post-contrast image. There were multiple dilated and tortuous vessels were seen, which were showing enhancement equal to the abdominal aorta, suggestive of a complex pulmonary arteriovenous malformation with aneurysmal dilatation of the vessel in the nidus. This is in this picture we can see this is the feeder artery, and this is the nidus, and this is the evacuator vein. Feeder artery draining into the nidus, and this is the vein evacuating from the nidus. Further, I would like to invite Dr. Suresh sir.
With the background of pulmonary AV malformations, possibility of AV malformations elsewhere in the body was also thought of. To further evaluate, a saline echo, USG whole abdomen, CT angio of whole abdomen, and CT angio head and neck vessels was advised. I would like to invite Dr. Yudhishthir from the Department of Cardiology to discuss the saline 2D.
Morning, sir. So, in this patient, just for residents, I just want to say, if a young male, young person coming to you with obvious cyanosis, first you have to confirm whether it is central or peripheral. So, clubbing is there, so it has to be central. So, if young male is coming to you walking, it has to be cardiac cyanosis until proven otherwise. AV malformation is also a cardiovascular cause of cyanosis. Why it is important? Anyone? Because it's a treatable cause. We can treat it because suppose lung cancer is there, some other disease is there, then it's difficult to treat, but it is easily treatable. Suppose patient is having tetralogy of Fallot, it's easily treatable disease. So in this patient, saline 2D echo was done using saline contrast, agitated saline contrast. As we inject the saline contrast in the vein, as it appears in our right atrium and right ventricle, if there is intracardiac shunt, it will immediately appear on the left side also. If it is extracardiac shunt, like vascular malformation in pulmonary AV fistula, it will appear after some time because the blood has to go RA, RV, pulmonary artery, pulmonary capillaries, and then pulmonary vein, and then left atrium. So it will take time. Time will be around 5 to 6 cardiac cycles. So in every case of cyanosis, if E2D echo is normal, it should be done in every case. It can be easily done, well tolerated, non-invasive. It uses microbubbles which remain in intravascular space and allow the simultaneous assessment of LV function also. So as we discussed, if it appears within 3 weeks, then it has to be cardiac shunt. If it appears later, then it has to be extracardiac shunt.
Excuse me, I think here what you are saying is this is a screening test for a pulmonary vascular ectasia or a pulmonary AV malformation. After an angio has been done and you have shown a big shunt, it is a great idea of doing an agitated saline. In the sequence, after the normal 2D echo, you should have done a bubble echo and found that there is a shunt and then proved it on the angio. Here you have already shown us the angio, there is a big fistula there, and now you are doing a shunt, and I don't think it doesn't sound very logical at this point.
Yes, sir, I agree with you. It should have been done before. Yes, I agree. In this case, first right sided of explication is there, and after few cardiac cycles, the contrast appears on the left side. It suggests extracardiac shunt. Yes, as sir said, it should be done when echo is done in case of cyanosis, because if young male is coming, young person is coming with cyanosis, walking patient is coming, then saline echo should be done simultaneously.
Further, sonography was done. In sonographic findings were suggestive of enlarged liver with dilated and tortuous hepatic artery and revealed an arteriovenous fistula between hepatic artery and hepatic vein. In this picture, we can see as the portal vein is normal, and on color Doppler, this is hepatic vein and hepatic artery, and the fistulous connection between hepatic artery and hepatic vein. In view of the sonographic findings, further CT angiography of the whole abdomen was advised, which showed hepatomegaly with multiple abnormal dilated vessels with high flow fistulas seen between hepatic artery and hepatic veins. There is also partial opacification of hepatic veins seen in the arterial phase, and celiac artery, common hepatic artery, and its branches were markedly dilated with few tiny foci of the calcifications seen in these abnormal vessels. These are the 3D reconstructed volume rendered images in which we can see this is the normal image. The normal pulmonary vessels look like this, and this is the normal celiac artery and the hepatic artery. And in this our patient, this is the pulmonary avium, and this is the arteriovenous fistulas between hepatic artery and hepatic vein, and the dilated hepatic artery and the celiac artery. Similarly, these are the maximum intensity projection images these are the normal findings, and these are the AV fistulas between the hepatic vein and artery, and these are the pulmonary AVM and dilated hepatic artery and celiac artery can be seen. And further CT angiography of brain and neck was advised, which showed no significant abnormality. These are the aortic arch and the branches, common carotid and internal carotid artery and external carotid artery all appear to be normal. Circle of Willis is also well opacified and well defined and it appears to be normal. So summarizing the radiological findings, a left pulmonary AV malformation seen with associated hepatomegaly with multiple intrahepatic high flow arteriovenous fistulas between hepatic artery and hepatic vein with few tiny foci of calcifications and a large celiac artery and hepatic arteries.
Excuse me, Dr. Tanya, I think we started off with epistaxis. So, we have shown extensive malformations in the lung and the liver. How do you explain the epistaxis in this patient? In the Little's area, I mean, were there any other vascular abnormalities? Would we specifically look for those branches on the image? The Little's area of the nose from where the bleeding happens. We have talked about this blood supply. So if we look it on the imaging and see the abnormality in that area.
Actually, CT angiography of brain and neck, there was no abnormality detected. We will see only the medium and large size vessels, high flow AV fistulas. On clinical examination, the patient had mucocutaneous telangiectasia. They are very small caliber vessels which are not visualized. And also, we will see on the CT angiography if any active bleed is there.
Maybe a rhinoscopy, anti-rhinoscopy would have shown you telangiectasia or mucocutaneous dilatations in the nose. That would be, I mean, there is blatant bleeding and there has to be an explanation.
I think that was already done in the clinical examinations.
And there should have been a bruit. When we auscultate the liver, if you have such large high flow fistulae in the liver, it would be very surprising not to have a bruit on the liver. Clinical examination, the population intervention.
So in this picture, no, sir. So these are the two vertebral arteries forming the basilar artery.
This one. So all these are branches of external
For everyone, whenever any image or report is projected, the identity of the patient must be passed. Everywhere. Except when it is a departmental audit meeting, closed door meeting. It is a public presentation, the identity of the patient.
So bringing everything together, we have a 24-year-old male with bluish discoloration and recurrent epistaxis, clubbing with oral telangiectasias, pulmonary AV malformations, high flow hepatic AV fistulas, and a possibly positive family history. What would be the possible diagnosis? We evaluated, since we have a possibly positive family history, we evaluated the generic vascular malformation syndromes. First we sort of cerebral cavernous malformations, which have cerebral malformations along with cutaneous capillary malformation. Hereditary hemorrhagic telangiectasias have arteriovenous malformations and mucocutaneous telangiectasias. They have epistaxis, skin telangiectasias, lung, brain, liver AVMs, capillary malformations and arteriovenous malformations, and cutaneous mucosal venous malformations. So with the history, we have a likely diagnosis of hereditary hemorrhagic telangiectasia, Osler-Weber syndrome. For a patient of hereditary hemorrhagic telangiectasia, Osler-Weber syndrome, what lies ahead, what to treat and what not to treat. The approach to the patient includes patients with HST needs a multidisciplinary approach for management of various complications because of AVMs. The challenges to treat are epistaxis management, gastrointestinal bleed management, liver AV fistulas, pulmonary AVMs, cerebral AVMs, anemia and anticoagulation. An ENT opinion was taken for the epistaxis. On nasal endoscopy, the blood vessels were prominent at the anterior septum where Cassibus plexus is present with no obvious nasal bleed. Patient was advised nasal saline drops for prevention of dryness. He was advised to refrain from nasal picking, and in case of epistaxis, he was advised to pinch the nose and lean forwards for 5 to 7 minutes after putting sterile hemocoagulous nasal drops. For pulmonary AVMs, therapeutic embolization is indicated in most of the cases. Interventional radiology opinion was sought for further management and if needed pulmonary embolization. I would like to invite Dr. Nikhil Bansal sir for the management of pulmonary AVMs.
Good morning, respected teachers and all my colleagues. So the patient was referred to us for the management of hereditary hemorrhagic telangiectasia. So I would like to give a brief about how the pulmonary AVM are. So they are the low resistant, high flow abnormal vascular structure that most oftenly connects from the pulmonary artery to the pulmonary vein, and they bypass the normal pulmonary capillary bed and results in a intrapulmonary right to left shunt. The physiological consequences actually depends on the degree of the right to left shunt, which includes the hypoxia, dyspnea and cyanosis. Pulmonary AVM are usually hereditary and mostly accounts with the hereditary hemorrhagic telangiectasia. Hereditary pulmonary AVM tends to increase in size over time and usually expand and become more evident in the second to third decade. I would like to ask the House, the resident majorly, about the difference between the AVM and the AVF, if any resident can tell. Any resident from the surgical branch? Yes. Yes. But still, sir. So in an AVM, there is a abnormal communication between the artery and the vein, and there is a conglomerated vessels are seen, which forms a bunch, and nidus is present in the AVM, as well as in the fistula. There is a direct communication in between the artery and the vein. There are pathological classification. It's divided into the three parts: the simple type, which accounts for the commonest and has a single segmental artery which feeds the malformation. The second one is the complex type, which has a multiple segmental feeding branch which accounts for 20% of the cases, and the diffuse type, which is a rare one, in which the diffuse form of the disease is characterized by hundreds of malformation. The patient can have a combination of a simple and a complex AVM within the diffuse lesion. In contrast to the systemic AVM, the pulmonary AVM does not affect the cardiac hemodynamic. Either the cardiac output, cardiac index, pulmonary capillary wedge pressure, heart rate, blood pressure, and echocardiogram are usually within the normal limit. The degree of shunt is what determines the clinical effect on the patient. The peripheral oxygen saturation is low, as expected, does not normalize with 100% oxygen. There are different manifestations which accounts in the hereditary hemorrhagic telangiectasia. It can occur in the nasal mucosa in a form of a telangiectasia, the pulmonary AVM, the hepatic AVM, cerebral AVM, and pancreatic AVM can be present. So we have to thoroughly evaluate the imaging of the patient from head to toe to look for the different area where the vascular malformation can be present. I will summarize it with the chart. In a brain, it can be present majorly as a brain arteriovenous malformation. For the screening, the MRI is needed, and for the diagnostic confirmation, the digital subtraction angiography is advised. In the spine, it is majorly the fistulas, which can be screened with the MRI and diagnosed with the DSA. For the lung, it is usually arteriovenous malformation, which can be screened using the agitated saline in echo, and further evaluated and characterized with the non-contrast CT, and the better one is the CT pulmonary angio. For the hepatic disease, these are the pulmonary AVM as well as the portosystemic venous shunting, which can be evaluated and screened with the ultrasound, and further characterization will be done with the CT angiography. For the nose, the clinical examination is majorly sufficient. For the stomach and for the lower GI, the endoscopy is a screening modality, and further cross-sectional imaging is not majorly needed. For the treatment part, for the ruptured brain AVM, the surgery with or without the embolization is the first line of treatment. For the unruptured AVMs in the brain, the gamma knife or the embolization or the combination therapy can be done. For the pulmonary AVM, there is a criteria. If the feeding vessel is more than 2 to 3 mm, then the embolization can be done. The surgery is considered as a second line. For the liver and AVM, the diuretics considered as a first line, and intravenous bevacizumab can also be given. For the GI bleeds, the screening for the first line treatment is the iron replacement. If it is not treated, then the endoscopic coagulation can be done. For the nasal, the conservative management with the humidification or the lotions can be applied. If not being treated as a second line of treatment, the endoscopic laser coagulation can be done. So in our case, the percutaneous transcatheter embolization is considered as a first line treatment and being done. The advantage is it is less invasive and can easily be repeated. The chances of the recurrence of the failure is less than 5%. The major indication for the treatment is to prevent the paradoxical embolization. Why it happens? Due to the right to the left shunt, it diverts the flow of the blood from the capillary and impaired the gas exchange as well as the venous thromboembolic filter. So now the thrombus can enter into the arterial system, and the chances of the stroke or the brain abscesses is very high. So we have to close these types of shunts, and we can prevent the lung hemorrhage also. So there are different material which is being used according to the diameter of the feeding vessel. If it is 3 to 8 mm, then the preferable choice is a coil. If it is more than 8 mm, then the occlusive devices like the plug or the occlusive balloons can be used with a combination of a coil or a liquid embolizing agent. So this one is the treating chart, how we should have to treat. As already told, if the vessel size is more than 3 mm, then we have to treat. If it is not, then we can keep the patient in a follow-up with the yearly evaluation whether the disease is progressing or not. If the disease is progressing, then we can re-evaluate the patient, and patient can be sent for the embolization. If not, then the yearly follow-up can be done. If the vessel diameter is more than a 3 mm, then the primary choice is a embolization, and the patient is kept on a follow-up. If he improves, then we can keep him on the follow-up on a yearly basis. If it is failed, then we can consider it for the surgery. In a lung cases, the lung transplant can be done. For the hepatic diseases, the ideal treatment is the liver transplant. So I'll tell you how we approach the pulmonary artery. It can either be approached from the jugular axis or the femoral axis. In our case, we have entered from the femoral vein, enters the right atrium, through the right atrium till then catheter is passed into the right ventricle. Through the right ventricle, the pulmonary artery is being cannulated, as shown in this diagram. So this is our case. So we have cannulated the left pulmonary artery, and the selective shoot is being done. As you can see, there is a large AVM supplying from the multiple supplying branches are being seen. So the long sheath, which is a supportive sheath, is being cannulated into the selective portion of the left pulmonary artery, and it is being fixed. It helps in supporting the other instrument to get into. So after inserting the long sheath, we took a selective shoot, and which shows a better evaluation of a large AVM. the plug is being deployed because the diameter of the vessel is more than 20 mm. So we have introduced a dumbbell shaped plug, which is a kind of a occlusive device as we use in the ASD and the VSD. So it's a different kind of anatomical device but works like an occlusive device. So this is the device which we have introduced into the left pulmonary artery branch. After producing the plug, when we took the shoot, there is still filling from the side of the plug, and the pulmonary AVM is still filling. So we have super selectively cannulated with the catheter from the side of the plug, and embolization with the liquid embolizing agent was being done. I'll show you a video how we introduce the pulmonary plug. So in the targeted vessel, first we cannulated the vessel with the catheter and the wire, and the desired location is being identified using the venogram. The vascular plug which vascular plug is being deployed after resheathing the catheter. With the angiogram, the position is being identified and can be repositioned. Once we confirm that the position is right, then with the unscrewing method, we can deploy this device. As you can see, once the device is being deployed, we can recheck whether we are in the right position or any refilling from the side is being done. Once we confirm that there is no side filling, we can remove the catheter. Like in this case, after embolizing from the side path and deploying the device, on a check shoot, there is a no filling of the AVM is being seen, and the upper lobe is being now well opacified with the contrast. So as a surgical management for the pulmonary AVM embolization is considered as a major option. In a liver disease, it is majorly supplying from the hepatic artery. So what happened? It stills the blood. The hepatic artery flow goes into the pulmonary vein and causes a pulmonary into the portal vein and causes a portal hypertension, and the patient present as a pseudo-cirrhosis because the majority of the blood is not going into the major circulation. Now it is going to the portal circulation, and due to the increase in the flow into the hepatic vein, the chances of the preload to the heart is also increased. So the first line of treatment is with the diuretics. If it is not works, then the transplant can be considered. Now I would like to call Chitresh for the further comment.
I would like to request Dr. Karan sir from the Department of Hepatology to shed a little light on the management of hepatic discharge as well.
I don't have any slide to show. Just a basic. Going back to the case. In case of hereditary hemorrhagic telangiectasia, in liver it is a unique thing. Liver has got dual blood supply, one via the artery, one via the portal vein, and outflow is single into the hepatic vein. Unlike other organ where there is single and artery and single vein, in liver since there are two inflows and one outflows, three permutations can happen. One is there can be connection between hepatic artery and portal vein. There can be connection between hepatic artery and hepatic vein, and thirdly there can be connection between portal vein and hepatic vein. Depending upon which type of connection is there, the manifestation will be different. Suppose there is a connection between hepatic artery and portal vein. So all of the arterial blood, instead of going into the hepatic vein, will be draining into the portal vein, leading to portal hypertension, which will lead to bleeding manifestation and ascites. For that, the first line treatment management is to control portal hypertension, give beta blockers, give diuretics to control the ascites. If it fails, then the final thing is liver transplant. Second manifestation is if the communication is between hepatic artery and hepatic vein. They will just behave like any arteriovenous connection. They will be leading to high output cardiac failure. The management will be on the basis of cardiac management, the preload reduction. And if there is a connection between portal vein and hepatic vein. What will happen is ammonia, which has to go to the liver, it will bypass directly to the hepatic vein, and which will be leading to episodes of encephalopathy. In that case, the management will be principally directed toward management of hepatic encephalopathy, lactulose, rifaximin, and other things. And if in all the things, if all the medical management fails, the final definitive treatment will be to change the liver so that all the connection can be redirected.
We'll be doing a quick review of literature. So, what is HSD? It is a vascular autosomal dominant disorder with variable penetrance. Prevalence rates are between 1:5,000 to 1:8,000. The majority of patients are unaware of the diagnosis of HSD. There are three types of HSD. HSD1 is the loss of function in endocrine gene. HSD2 is loss of function in ACVRL1 gene. And JPHD is a juvenile polyposis HSD overlap syndrome with the loss of function in SMAD4 gene. Clinical constellation of symptoms include epistaxis, GI bleed, and iron deficiency anemia, which is associated with telangiectasia on the lips, oral mucosa, and the fingertips. Diagnosis: it is made by the Kirkhout diagnostic criteria. Our patient was fitting in the definite criteria. Our patient is spontaneous and recurrent epistaxis, multiple mucocutaneous telangiectasia, and visceral involvement, GI telangiectasia, pulmonary, cerebral, and hepatic AVMs, and the first degree relative with HSD. This is the pedigree analysis of the patient. Nasal telangiectasia and epistaxis. The mainstay of the epistaxis care is the replacing the lost moisture to prevent cracking. Anemia, it is the most common complication in people with HSD. It is typically diagnosed in adulthood, and primary etiology is iron deficiency, secondary to chronic mucocutaneous bleed. GI telangiectasia is developed in 30% of HSD patients, typically manifesting in 5th to 6th decade. Esophagogastroduodenoscopy remains a diagnostic gold standard for upper GI telangiectasia. Mild to moderate GI bleed involves tranexamic acid usage, and moderate to severe patients can be treated by IV bevacizumab dosing of 5 mg per kg every alternate week. Hepatic AVMs, the mean age of patients is 48 years, as explained by Karan sir. Hepatic artery, hepatic vein, and portal vein might lead to higher cardiac failure, portal hypertension, encephalopathy, biliary ischemia, and mesenteric ischemia. The severity of HSD-related GI bleed has been classified into mild, moderate, and severe based on the replacement. Oral iron can, if it is replaced by oral iron, mild HSD-related GI bleed. IV iron, moderate, and if it does not meet the hemoglobin goals, it is severe HSD-related GI bleed. Pulmonary artery venous malformation, as explained by Dr. Nikhil sir. It allows the systemic venous blood to bypass the normal pulmonary circulation, which results in cyanosis, clubbing, bruit, dyspnea, paradoxical embolism, and cerebral abscess. The future treatment modalities: there are no therapeutic, no mechanism-based targeted therapy available so far. Tacrolimus, pesopanib, and nintedanib are the major drugs that have been used in HSD to decrease epistaxis. We reviewed case reports from international and Indian journals. These are few case reports that we reviewed for the case. The patient progressed after a 3-month follow-up course. Patient's hemoglobin has improved to 14.2 grams. Hematocrit has improved to 39.9. MCV has improved to 95.6. The headache is relieved, and there are no recent episodes of epistaxis. The take-home message: cyanosis without symptoms should not be ignored in young adults, and necessary investigations are warranted. Common clinical manifestations can be a part and parcel of rare disorders. Interdepartmental coordination always gives a better understanding. Radiodiagnosis colleagues have published this article in Indian Journal of Vascular and Endovascular Surgery 2023. I would like to extend thanks to Dr. M. L. Swanka sir, Emeritus Chairperson, Achal Kolati sir, Vice Chancellor, Dr. V. K. Kapoor sir, Vice Chancellor, Dr. N. D. Soni sir, Principal, Dr. Jane Saxena sir, Emeritus Professor, Mahatma Gandhi University. I would like to thank Department of Radiodiagnosis, Intervention Radiology, Department of Hepatology, and Department of Cardiology for helping us with this.
I guess सबसे ज़्यादा thanks to Interventional